Thank you, David. Sally.
Great. Thank you. Thank you for the invitation. My name is Sally Howard, and before joining Human Longevity, I was Deputy Commissioner at FDA and was the liaison with the President's Precision Medicine Initiative. And I credit that initiative with really highlighting the tension between HIPAA and CLIA. It really, as part of that planned, that it was going to be all of us, was a planned return of results, planned interaction with participants around their data. It raised in that context, what about the quality systems? What about lack of quality systems? What should we do with research labs that aren't CLIA certified? So all of those issues were raised, and I believe that based in part on the President's Precision Medicine Initiative, I think all those discussions stirred then the rule that was issued, the joint rule between CMS and OCR, enlarging the patients or participants' right to certain data. Really started to talk about what about the designated record set? Does it include research results? And was really trying to find a lot of ways to legally afford the participant in the study an ability to acquire that data upon request. Still upon request, not so much promoting, but upon request would be able to obtain that data. And I think that was an important component to the Precision Medicine Initiative. I was the public health voice then raising concerns about CLIA in that context, and I'm going to stay there a little bit. My concern is simply that in the forward, planned delivery of results, not using a CLIA certified lab, that there just isn't a floor. There's not a quality floor. There's a number of institutions who I think would have the types of quality systems that are required by the CLIA rules, but there's other, I think we heard earlier today, there's other, general discovery happening out there that's really not as interested in the quality system, the chain of custody, all of those proficiency testing types of things, and to treat all of the labs the same as you determine whether or not it's appropriate to return results to participants, I think would be a mistake. So as I was thinking about how I would approach potential policy changes, to me, it broke down, as I believe Susan suggested. One is, where you plan to return results up front, and the second, where you don't, but you encounter results that pose ethical issues if you don't return them. I think all three of us would agree that the notion that this body might consider suggesting to CMS that it modify its position, that signaling the need for a CLIA-validated test, signaling that there was a result of concern that should be considered, that should be tested, or that the individual should obtain testing via a CLIA-validated test, that somehow in and of itself constitutes a return of results that then puts them in violation of the CLIA rules. I think that would be one where I hear us uniformly suggesting that would be a fine place to make a modification. I think the other question in this category, again, of unexpected findings would be what to do with the unexpected finding. Would it be sufficient for you to return the test, and with the caveat that this is research use only and should be confirmed by a CLIA-validated test? So that gets to the second rung. One is you don't really give the findings, but you tell them there was a finding and you need to have it validated. I think that's where this panel all agrees that policy choice might be recommended. The second one is, what about just returning the results, having a disclaimer that it's research use only, and telling them that before any clinical action should take place, they should get them clinically validated or validated with a CLIA-validated test. I personally, just again from my FDA perspective, have a little more concern about that, and my concern about that is that you are giving the result to someone, and again, if it was not generated in a CLIA-validated lab, I don't know what confidence you have in the accuracy of those results, unless, again, there is a quality system around there that covers both chain of custody, that involves testing, validation testing of the machines that are running the test, that governs the people who are doing the tests, and all the other things that CLIA validates. But again, I think that would be a second issue, is does returning that with a direction that you should have it confirmed with a CLIA validated test, that would be another policy option, that where there is not a plan to return results, but something comes up, that CMS might also consider modifying its position to allow return of the results with a big RUO disclaimer that says, don't take any clinical action on this, and you should have it confirmed with a CLIA validated test. But I think that would be a little more risky. Part of these, as you consider different policy options, I know that part of the conflict that we see is that HIPAA grants the participant certain rights to data, where CLIA says, we don't care, any result is a return of results and you have to meet CLIA. In the wide world of research, not only are there a number of labs that are not CLIA certified, but there's also, I would imagine, a number of labs that aren't part of a covered entity, or are not part of or are not a covered entity themselves because they don't do third-party billing. For those entities, I would hope that this panel would think about that instance, because HIPAA then doesn't apply. There is no right to access at that point in time. And so it really would have to be solely within the CLIA laws that a modification was made that would recognize some sort of limited, narrow exception where there was an unexpected return of results that the researcher felt ethically required to provide, with, again, an RUO disclaimer. So in the planned results, I think it's easier to think about, from a policy and legal changes perspective, a world where there are these unexpected results versus a world where we plan at the very beginning to provide results. And I think at that point in time, just having worked with Office of Civil Rights and the CMS and FDA, you'll have a harder time convincing CMS and the FDA that non-CLIA certified labs should be able to provide participants with results from if it's a non-CLIA certified lab, then the assay also has likely not been validated to the level required by CLIA and CAP. And especially as I hear many people saying that there are CLIA certified labs available, one would imagine that you're not forced into that box of allowing all research labs to be able to provide prospectively these types of these results. And I would opine that whatever policy changes are made in that realm should, at the very least, require, again, I think the three agencies to get together to talk about, if it's not CLIA certification, what is that level of quality systems around the process, the machines, the qualification of reagents, the qualification of personnel, the proficiency testing. What is the level of quality systems that we need to have in place for us to feel confident that the results that are being delivered to participants can be relied on to the degree that CLIA hopes to put a floor in place to ensure that there is that level of accuracy, confidence, and accuracy machine to machine versus as well as operator to operator. And without those quality systems, I'm just not sure how you would justify providing those results up front. I've seen in my work at Human Longevity, they started out as a research lab, then got CLIA certified. It is no small feat to become CLIA certified. There is really a difference, in cost and in overhead costs, because you now have a laboratory director. I'm assuming that most of the testing that we're going to be talking about is genomic testing, would likely be high complexity type testing. And so those requirements would be what we're talking about, the cost of the burden of being CLIA certified. You would need the lab director, the general supervisor, the technical supervisor. These are all people who are advanced degree people who are then certified that they know how to run this process. You have some sort of a LIMS system on top of it so that you do have that chain of custody from beginning to end. So all of that is costly, is burdensome, is something that should be considered before any recommendation that everyone should be a CLIA certified lab. And then the assay validation is no small feat. I mean, if we are going to have like CLIA certified labs and an assay validation on some level, that could require sample acquisition costs, the cost of the reagents that are needed to just run the pipeline, the number of times that you would need to be able to, again, determine what is the performance characteristic of that test. But if, and none of that is required in a research lab. And again, I don't know that would want to require that of a research lab, because a great deal of research is discovery. And how much should we be spending on the level of confidence that we would want in order to return a result to somebody versus the level of confidence that we want in order to assure a high-grade research is being done. I think, I leave that to the panel to decide what that recommendation would be. But again, the validation of the assay, as I have found, because now we're a CLIA certified lab, we run both research assays and CLIA validated assays. It's a very different process. And I would tell you that researchers and clinical laboratory people are worlds apart in their thinking. And just how they approach the process of running an assay. I think that a good deal of the discussion here is around genomics, partly, I believe, because that's where a lot of it's the precision medicine initiative, I feel, is driving a lot of this discussion. I don't really have a view on how it would apply to, non-genomic type research, and whether I think the similar issues that Susan raised would apply there. So finally, again, with the IDE issue, I think that to me the conflict there is more of it's not really a conflict, but it's something to think about, that again, if you are prospectively going to be delivering results to people, you will need to confirm with a CLIA validated test, or you will not fall within the exemption of the IDE, and then you'll have to ask yourself, is it significant risk or non-significant risk? And I think NHLBI put out a paper recently to give researchers guidance on that topic about what would a significant risk versus non-significant risk be, and they noted that FDA would likely allow you to return that BAM file up front, and I think I would tell you from my time at the FDA, they would likely allow that, because if all you're doing is returning the data, they would not consider that laboratory developed test to be a device. I think it's only when you start it's the interpretive piece, it's when you start returning the variant information that tells someone, that conveys to someone the variant and the link to the disease, that I think, in my mind, that's part of what's triggering on the FDA side, that it becomes then the device, and that the IDE stuff then applies. And in the direction given by the FDA, if you confirm with a CLIA validated test any result that is going to be returned, I think you still fall within the exemption. Otherwise, you go through the significant risk, non-significant risk analysis, and in the NHLBI guidance, they suggested that if you're returning results to a healthy person, you'll likely be falling into the significant risk. And at that point, you then need to make your FDA filing. And so I would, again, say, like, what burden, where is the burden falling? Because it seems like you've got CMS and FDA as the public health entities that are wanting to make sure that some level of validation has been done and some level of protection happens, whether it's through the IDE process or the CLIA validation process, before you give results back to an individual that they may use. And I don't think either agency would accept a simple disclaimer that this is RUO as a sort of as a blanket way out. And I'll stop with that. Thanks.